Good afternoon, everyone. Today I am going to talk about the drugs for the schizophrenia. Okay, drugs used in the treatment of schizophrenia. So, brief introduction of schizophrenia. It is thought due to severe psychiatric illness, and it is thought due to dopaminergic overactivity in the limbic system. Yesterday we have seen that. Okay, so positive symptoms. So other neurotransmitters like 5-HT in case of negative symptoms, and noradrenaline also probably play a role in this disorder. So all drugs for the schizophrenia, they have equal efficacy. Only they differ in the potency. That's why in the first generation we have low potency, mid potency, and high potency. And all these drugs have equal efficacy. They can be classified as typical D2 blockers and atypical, acting through different mechanisms. So typical drugs like haloperidol, they block dopamine receptors in the mesolimbic system. And atypical will block through different mechanisms like 5-HT2 antagonism, 5-HT1A agonism, like these things. So now I am going to talk about only the typical antipsychotics. Okay, actions of typical antipsychotics. So these drugs act by blocking the D2 receptors, the mesolimbic system, and they differ significantly in the potency. That's why we have low potency, mid potency, and high potency. And low potency drugs we have chlorpromazine, okay, chlorpromazine and thioridazine. These drugs are highly sedative. But if you talk about the high potency drugs like haloperidol, they cause less sedation. And high potency drugs, they are more likely to cause extrapyramidal symptoms because high potency means they can block the dopamine receptors much more compared to your low potency. So they have the high potency to block your dopamine receptors. So if you block the dopamine receptors, the dopamine acetylcholine balance will be altered, acetylcholine will be enlarged. So that's why the cholinergic system will be enlarged. So it will produce your extrapyramidal symptoms. So it is maximum with your haloperidol and the least with your low potency drugs like thyroidazine and chlorpromazine. So the high potency drugs have low anticholinergic side effects, have low autonomic side effects as compared to your low potency drugs. So high potency drugs, the problem is extrapyramidal symptoms, and the low potency drugs like chlorpromazine and thyroidazine, the problem is anticholinergic side effects and autonomic side effects. They are much more common in low potency drugs comparing to your high potency drugs. So these low potency drugs can also lower your seizure threshold. It can produce seizures. They can precipitate convulsions in epileptic patients, particularly your chlorpromazine and thyroidazine like drugs, low potency drugs. They can lower your seizure threshold and can precipitate convulsions in your epileptic patients. So all of these drugs, they are potent anti-emetic. All the psychiatric drugs are anti-emetic drugs. Okay, the phenothiazine drugs, because they block the dopamine receptors. So dopamine receptors are present in your CTZ and vomiting center. So if you block the dopamine receptors, it can help you in your preventing the vomiting or treating the vomiting. Okay, so they are all of them are potent anti-emetic except your thyroidazine. Okay, exception is thyroidazine. It can produce vomiting. So I have told you that low potency drugs they can cause anticholinergic side effects, alpha blocking effects. The alpha blocking effects, postural hypotension, is maximum with your chlorpromazine. If you talk about the anticholinergic side effects, it is more common with your thyroidazine drugs. Okay, so alpha blocking property more with your chlorpromazine, and anticholinergic drugs, anticholinergic property is more common with your thyroidazine. And high potency drugs have very less activity on these receptors. So due to the blockage of dopamine receptors in hypothalamus and pituitary, there is this tubero-infundibular pathway, tubero-hypohysial pathway. These drugs can increase the prolactin. Yesterday we have discussed. So they result in galactorrhea and amenorrhea. So increase in prolactin can also cause your infertility through amenorrhea. Sorry. Okay. And what are the long-acting injectable antipsychotics? We have those who don't take by mouth. So they have prepared long-acting injectable antipsychotics. We can give monthly dose, monthly once. That's enough. Okay, because they have having long half-life because of long-acting. We have fluphenazine decanavate, haloperidol decanavate, risperidone microspheres, paliperidone palmitate, and recently we have olanzapine and aripiprazole also. So these are the drugs they are given for uncooperative patients. Those cannot take by mouth. So we can give once monthly IM injection. That is fluphenazine and haloperidol. They are the first generation drugs. And all of these are risperidone, paliperidone, olanzapine, aripiprazole are second generation atypical antipsychotics. And paliperidone is metabolite of your risperidone. Okay. So fluphenazine decanavate, haloperidol decanavate, risperidone microspheres, paliperidone palmitate, olanzapine, and aripiprazole. Now coming to the actions of atypical antipsychotics, how they act. So they have very less dopamine blocking activity. They have more action on your serotonin receptors. So they have more action by antagonist action on your 5-HT2 antagonist, 5-HT1A agonist. Yesterday we have discussed. And also they can also block your alpha receptors also. Okay. So they block by antagonist action at 5-HT2 and alpha receptors. And also 5-HT1A agonism. So they may or may not possess your dopamine blocking activity. Only atypical antipsychotic, they have dopamine blocking activities risperidone. Okay, risperidone. So because of very less activity on the dopamine, they are less likely to produce your extrapyramidal symptoms. And most of these agents produce your weight gain, hyperlipidemia, they can cause metabolic syndrome, new onset diabetes. Exception is ZA, okay, ziprasidone and aripiprazole. They produce very less weight gain, okay. So they are safe in such cases. They will not produce your metabolic syndrome, weight gain, hyperlipidemia. ZA, ziprasidone and aripiprazole. Coming to the individual drugs, thyroidazine, I have told you, they have the least incidence of causing extrapyramidal symptoms because they are low potency drugs. They are block dopamine receptors much low comparing to your high potency drugs like haloperidol because of your low potency D2 blocking activity, and they have the presence of central anticholinergic activity. So they have the most anticholinergic side effects, and also they are blocking the alpha receptors, so they can cause male sexual dysfunction by inhibiting ejaculation due to alpha blocking activity. They can also cause postural hypotension, and thyroidazine can also precipitate arrhythmias because of increase in QT interval. Okay, so these are the things with thyroidazine. And main problem with your thyroidazine is retinal damage. On long term, it can produce retinal damage. So it has least incidence of extrapyramidal symptoms, and it has more potent anticholinergic activity. It has alpha blocking activity, so it can produce sexual dysfunction by inhibiting ejaculation. Can cause cardiac arrhythmia because of increase in QT interval, and long-term administration can cause retinal damage. Now coming to other high potency drugs like trifluperazine, fluphenazine, haloperidol, they are high potency drugs. So they have least alpha blocking activity, they have least anticholinergic activity, they have least selective activity, and they have least pro-convulsant action. So they will not produce seizures like your low potency drugs. But because of high potency drugs, they block the dopamine receptors more, and so that the extrapyramidal symptoms are much more marked here. And which is the longest acting antipsychotic drugs is penfluridol. Okay, the pen is very long, so this pen is very long, so penfluridol is the longest acting drug. Other important long acting drug is pimozide. Okay, they also block your dopamine receptors without affecting your alpha and muscarinic receptors. So they don't have alpha blocking effects, they don't have anti-muscarinic or anticholinergic effects. They have long duration of action, but the main problem is they can also, like thyroidazine, it can also prolong your arrhythmia. By QT prolongation, they can cause torsades pontins. Now coming to the clozapine, which is an atypical antipsychotic drug. I have told you that atypical antipsychotic have very weak dopamine blocking action. How they will act? They will act by 5-HT2 blocking action, and they also block your alpha receptors, and they also block your D4 receptors. Okay. So clozapine is an atypical antipsychotic. They can block by 5-HT2 receptors, alpha and D4 blocking activity, and they have very weak D2 blocking activity. So the extrapyramidal symptoms are not common here. So the advantage of clozapine is it can suppress both of your positive as well as negative symptoms of schizophrenia. So it is used only as a reserve drug. So when other drugs don't work, then we can give clozapine. Drug resistant psychiatric or drug resistant schizophrenia, the drug of choice is clozapine. So it is used as a reserve drug because of the side effects it can precipitate, like seizures and agranulocytosis. Okay, this is important thing. MCQ point of view, seizures and agranulocytosis it can cause. And convulsions are dose dependent. So increasing the dose can cause your convulsions. But agranulocytosis is independent of the dose. A single dose in susceptible patients it can cause agranulocytosis. So convulsion is dose dependent and agranulocytosis is dose independent. And clozapine has also associated with myocarditis. So it should not be given in patients with, it is contraindicated in patients with severe heart disease. And clozapine is also having powerful anticholinergic activity. So equivalent to chlorpromazine and thyroidazine. In the first generation drugs, low potency drugs also have anticholinergic side effects. We have seen chlorpromazine and thyroidazine. So clozapine also has powerful anticholinergic side effects like your chlorpromazine and thyroidazine. Remember CTC, okay? CTC can cause your anticholinergic side effects. What are the CTC? Clozapine, chlorpromazine and thyroidazine. And if you talk about the clozapine, it has very low D2 blocking action because it's an atypical antipsychotics. So the risk of extrapyramidal symptoms is least with the use of drugs. And another important side effects because of the anticholinergic side effect, it can stop your GI motility, so it can cause severe ileus. And because of D4 activity, it can cause increase in salivation. Okay, this is opposite to your anticholinergic activity. It is an exception. It can cause sialorrhea. Okay, sialorrhea is an important side effect of clozapine because of D4 activity, dopamine 4 activity, dopamine 4 receptors. Okay, D4 receptors. And severe ileus is because of the anticholinergic activity. Now coming to the risperidone like clozapine, it also blocks your 5-HT receptors. It also blocks your alpha receptors. But it also blocks, opposite to your clozapine, it also blocks dopamine receptors. It is a more potent D2 blocker. Okay, the only atypical antipsychotic which has more potent D2 blocking activity is risperidone. So it is more potent D2 blocker than clozapine. So they can cause extrapyramidal symptoms because they also block your dopamine receptors at high doses. And opposite to your clozapine, the risk of precipitation of seizures is less compared to your clozapine. Okay. So risperidone acts by blocking 5-HT receptors. They can also block your alpha receptors. Opposite to your clozapine, they also block your D2 receptors. Because of blocking D2 receptors, it can precipitate extrapyramidal symptoms at high doses. And opposite to your clozapine, it will not precipitate your seizures. It is seizure safe. And because of blocking D2 receptors, hyperprolactinemia can also be reported with the risperidone. Because of D2 blocking activity, there will be much more increase in prolactin in tubero-infundibular pathway. Okay, than any other atypical antipsychotics. I have told you that active metabolite of risperidone is paliperidone. It is also useful as once monthly injection, and it also has lesser risk of causing adverse effects. Okay, paliperidone is also safe drug, but paliperidone is reported to cause your QT interval also. Remember, paliperidone can also cause QT interval. Now coming to the olanzapine. Olanzapine has also similar mode of action like your risperidone. It is a potent anticholinergic. Okay, it can cause, because of anticholinergic activity, it can cause dry mouth, constipation. It can cause seizures and weight gain. And remember, seizures we have COC. Okay, remember COC. C for clozapine, O for olanzapine, and C for chlorpromazine. Okay, COC can cause seizures. CTC cause anticholinergic activity. Okay, CTC is anticholinergic activity. I have already discussed. COC can cause seizures. Clozapine, olanzapine, and chlorpromazine, they can cause seizures. And main problem with your olanzapine is they can cause weight gain and metabolic disorders. It's much more common with your olanzapine. The metabolic disorders are much more common with your olanzapine. They can cause higher risk of stroke and death. MI, metabolic syndrome are common here. And another specialty of olanzapine is they are used in acute mania and bipolar disorder. Okay, they can replace your lithium. Now I am going to talk about ziprasidone. Ziprasidone, I told you it is safe from the metabolic abnormalities. Okay, ZA. Ziprasidone and aripiprazole are safe from your metabolic abnormalities. ZA is safe from the metabolic abnormalities. But problem with ziprasidone is it can cause QT interval and can increase the risk of arrhythmia. So, like another antipsychotics, it is not associated with your weight gain and hyperlipidemia, diabetes. So, ZA is safe in your weight gain, hyperlipidemia, diabetes, metabolic syndrome. Coming to the QTFN, it can cause your cataract formation. It has short of life. So, the important point to remember is cataract formation. The two psychiatric drugs which can affect your eye is thioredoxin. Thioredoxin causes retinal pigmentation, retinal damage, and QTFN can cause your cataract formation. Aripiprazole, I have told you that it has dopamine partial agonist activity, and also it has 5-HT1A partial agonistic activity at both of these receptors. So 5-HT1A and dopamine receptors. So the mechanism of action is different, and it also has 5-HT2A antagonist activity. So 5-HT2A antagonist, 5-HT1A agonist, and dopamine agonist. So they are called as dopamine serotonin stabilizer. Okay, it has quite long half-life. Where are the conditions we are using aripiprazole? It is used in autistic disorders for the treatment of irritability associated with autistic disorders in the children. It is also the drug of choice for your nowadays. They are given for Tourette syndrome. Okay, Tourette syndrome. Aripiprazole is the drug of choice nowadays. It is given in the Goodman-Gleiman. So aripiprazole is a partial agonist activity at 5-HT1A at dopamine, antagonist activity at 5-HT2A receptors. It is a dopamine serotonin stabilizer. It has quite long half-life. It is indicated for irritability associated with autistic disorders in the children. It is a drug of choice in Tourette syndrome. Asinapine is the only psychiatric drug which is given sublingually. So name the antipsychotic drug which is given sublingually. That is asinapine. Okay, asinapine is used sublingually for schizophrenia, and it is also indicated for acute mania also. And iloperidone has lesser risk of extrapyramidal symptoms because second generation drugs, they will not block your dopamine receptors much like your first generation drugs. And problem with this, it has alpha bucking activity. Okay, so it can cause orthostatic hypotension, and it can also prolong your QT interval like ziprasidone. It can precipitate torsades pontis. So iloperidone safe for your extracerebral symptoms. It can cause orthostatic hypotension because of alpha bucking activity like ziprasidone. It can also prolong your QT interval. Newer drugs approved for schizophrenia is brexpiprazole and cariprazine. BC, okay. Brexpiprazole and cariprazine are newer drugs approved for your schizophrenia. So coming to talk about the adverse effects, sedation is common with your low potency drugs like chlorpromazine, and weight gain with all except ZA, ziprasidone and aripiprazole, and aggravation of the seizures with COC, clozapine, olanzapine and chlorpromazine, and aggravation of the anticholinergic side effects with CTC, same clozapine, chlorpromazine. Instead of T we have to put thyroidazine. Okay, for T we have to put thyroidazine. CTC anticholinergic activity, COC seizures, and less chances with risperidone and quetiapine for your they will not block your dopamine receptors. Okay, so they will not produce seizures, they will not produce extrapyramidal symptoms. And postural hypotension and inhibition of ejaculation due to alpha bucking activity. This is produced by your low potency drugs. Okay, alpha blocking activity. And weight gain is present with all except your haloperidol. Okay, and three drugs they are reported to produce weight loss: bolindone, haloperidol. Okay, bolindone, haloperidol. Remember these drugs: bolindone and haloperidol. Okay, so all atypical antipsychotics causes metabolic side effects. Okay, except your ziprasidone and aripiprazole. Is that it? Okay, and metabolic side effects is more common with your olanzapine and clozapine. Okay, CO is more common for your metabolic side effects, and most common with your olanzapine. And retinal degeneration is seen with your thyroidazine, and cataract with your quetiapine. And agranulocytosis is seen with clozapine. Cataract formation with quetiapine. Cholestatic jaundice with chlorpromazine, C for C. And thyroidazine is reported to produce anticholinergic side effects like constipation, dry mouth, blurred vision, urinary retention. And because of D2 blocking activity, your first generation drugs like haloperidol, high potency drugs can cause hyperprolactinemia, infertility because of amenorrhea and galactorrhea. And first generation drugs, because of blocking D2 receptors, they are producing extrapyramidal symptoms. And second generation drugs, we have risperidone. Because of anticholinergic side effects, we will get acute muscular dystonia. Okay, it's like they can manifest within the hours. They can manifest as torticollis, locked jaw, oculogrysis spasm, oculogastric crisis, spasm of other muscles, locked jaw. So central anticholinergics are the useful in the treatment. For example, benzhexol, trihexyphenidyl, procyclidine, piperidine, benzotropine, orphenadrine. So drug-induced Parkinsonism, other side effects. They can establish between 1 to 4 weeks of the therapy. Similarly, same treatment is used. Central anticholinergics also useful. Benzhexol are useful in the treatment. And another important side effect of your antipsychotic drugs is akathisia. Akathisia is irresistible desire to move in the absence of anxiety. Okay, the patient cannot sit in one place; he want to move. Irresistible desire to move in the absence of anxiety. It is the most common extrapyramidal symptoms. The drug used here is propranolol. And cigarette smoking is associated with increased risk of akathisia, and propranolol is the preferred drug for this condition of akathisia. Other central anticholinergics also useful for the treatment of akathisia. Coming to another important side effect, malignant neuroleptic syndrome. They can present as hyperthermia, autonomic instability, and generalized rigidity and altered mental status. The drugs treated for this condition is IV dantrolene and bromocriptine. Okay, IV dantrolene and bromocriptine. And tardive dyskinesia, yesterday explained the mechanism. Because of blocking your dopamine receptors for a long time, there will be upregulation of the new receptors. Because of the upregulation of the new dopamine receptors, it can produce purposeless involuntary movements like rabbit chewing, puffing of cheeks. So there is no satisfactory treatment for the conditions. But you should not, the central anticholinergic drugs are contraindicated in the case. But nowadays the latest drug approved for this condition is tetrabenazine and valbenazine, which are BM82 inhibitor. Okay, tetrabenazine, valbenazine, BM82 inhibitor, a drug of choice for tardive dyskinesia. Sodium valproate also has activity in tardive dyskinesia. So what are the other uses of antipsychotics? They can be used in mania, bipolar disorders. I have told you about olanzapine, a drug of choice in acute mania and pregnancy. Asinapine can also be useful for acute mania. Haloperidol is safe in your pregnancy. Okay, an alternative to that electroconvulsive therapy in severe depression with psychotic features, we can use antipsychotics. And usually, these drugs can be useful in alcoholic hallucinations and Huntington's chorea, Gilardi-Tourette syndrome. Haloperidol is the drug of choice. And if you talk about haloperidol and fluphenazine, they are the most typical antipsychotics, and risperidone is most typical atypical antipsychotics. Okay, they are the most potent, and if you talk about most potent, haloperidol and fluphenazine are typical antipsychotic drugs, and risperidone is most potent atypical antipsychotic drug. And risk of extrapyramidal symptoms is negligible with cock. Okay, with clozapine, aripiprazole, quetiapine, because they have very less activity on the dopamine receptors. Clozapine, quetiapine, and aripiprazole. So CTC has more anticholinergic activity: chlorpromazine, thyroidazine, and clozapine. And fluphenazine, enanthate, and haloperidol decanavate, they are long-acting injectable IM or SC subcutaneous forms of typical antipsychotics. And risperidone is the first atypical antipsychotic available in the long-acting injectable form. Other drugs are aripiprazole, olanzapine, paliperidone. So most commonly used antipsychotic drugs is intravenous route is haloperidol. Okay, and which drugs produce less metabolic adverse effects is ZA, ziprasidone, and aripiprazole. Other drugs which can have negligible risk to cause metabolic adverse effects are asinapine and iloperidone, Xy. So remember, add AI along with that. ZA to AI. Okay, and which drug has the most potent to cause prolonged the acute interval is ZAP. Asinapine can cause prolonged acute interval, paliperidone and ziprasidone and iloperidone also. Okay, so ZAP, remember ZAP, ziprasidone, asinapine, and paliperidone, iloperidone. They have the most potential to prolong the acute interval. So these are for the antipsychotic drugs today, and we will discuss other topics. Thank you for your kind attention.